Yes,
This
sir. Yes.
conference will now be recorded.
Okay, I will start. Good morning, everybody. Yesterday's topic I am continuing. The most important complication of cirrhosis is hepatocellular failure, hepatic failure. So we will proceed with the discussion of hepatic failure. What is hepatic failure? Hepatic failure is a clinical syndrome that occurs when the liver function is inadequate to sustain metabolic, detoxifying and synthetic activities. Liver performs a number of activities. Some are metabolic activities. It is concerned with metabolism of proteins, carbohydrates and fats. It detoxifies chemicals and drugs, and also many toxic agents that are coming from the gastrointestinal tract. After absorption, the food along with some products of bacterial toxins also enter the liver, such as ammonia, which is detoxified by the liver, normal liver. So, and synthetic activities are protein synthesis mainly. It is involved in synthesis of albumin and globulins. Particularly coagulation factors are synthesized in the liver. So all these functions are affected in hepatic failure. Hepatic failure may develop acutely or chronically. Acute hepatic failure occurs within 3 to 6 weeks after acute viral hepatitis or toxic chemical or drug induced liver injury, or it may occur chronically in the context of chronic hepatitis or cirrhosis. And you can see here the important signs, clinical signs of hepatic failure. Jaundice is important symptom and sign, and hepatic encephalopathy is most serious condition which could be fatal. And the hepatic failure also contributes to ascites. Ascites is accumulation of fluid in the peritoneal cavity, and because of lack of synthesis of coagulation proteins, coagulation factors, the patient may develop a bleeding tendency, bleeding into the skin, purpura and petechial hemorrhages, or from the gastrointestinal tract. So bleeding tendency is also developed, and along with it, there are other features like hypoglycemia, acidosis, and endocrine disturbances are also occur, because the liver is the site of the degradation of many steroids produced by adrenals. So jaundice is because of inadequate or reduced metabolism of bilirubin synthesis, and excretion is deranged in cirrhosis. Therefore, hepatic failure leads to jaundice. So from this picture you can see from top to bottom there are manifestations or complications of hepatic failure. Most important is hepatic encephalopathy, which I will discuss in detail. Next, jaundice. Jaundice is because of improper metabolism of bilirubin and also bile salts. And you can see here some of the manifestations. Ascites is because of hypoproteinemia. Albumin is most important protein which exerts oncotic pressure. So reduced albumin synthesis, hypoalbuminemia, leads to hypoproteinemia and reduced oncotic pressure, reduced plasma oncotic pressure. So this facilitates collection of fluid in the peritoneal cavity and also in the subcutaneous tissues. Patient also develops generalized edema and effusions. So that is the ascites, and you can see here gynecomastia and testicular atrophy in male, palmar erythema and spider nevus spider nevea are capillary dilatations in the skin, and palmar erythema is redness of the skin on the palms, and testicular atrophy, gynecomastia. These are because of disturbances in the metabolism of sex hormones. Normally, in the male, estrogens which are produced by adrenal cortex are metabolized and degraded in the liver. So we don't have an effect of estrogens in the normally, but the liver is failure. Therefore, the degradation of estrogens is defective. Therefore, patients develops hyperestrogenemia, which manifests as gynecomastia, testicular atrophy, palmar erythema, and other things. So, most important complication of hepatic failure is hepatic encephalopathy. Hepatic encephalopathy is one of the most serious complications of hepatic failure. It may occur in acute hepatic failure or chronic hepatic failure. And it may be related to toxic compounds which are absorbed from the intestine, particularly ammonia, which is released from the intestine by the action of bacteria, intestinal bacteria on the proteins, dietary proteins. So ammonia that is released comes to liver for degradation. It is degraded and detoxified into the urea. Urea is synthesized from ammonia. So and it is excreted by the kidneys. Because liver is at failure, ammonia is not degraded, and also the portal photosystemic anastomosis develop at various levels because of portal hypertension, and the bypassing of ammonia leads to development of toxic symptoms due to CNS injury. So there is brain edema and various manifestations of neurological manifestations, and also the various other compounds are all toxic compounds are also not detoxified by the liver. And hepatic encephalopathy is a neuropsychiatric syndrome, which may complicate liver disease of both acute and chronic types. And features are disturbed consciousness, personality changes, intellectual deterioration, slow and slurred speech, flapping tremor, and finally coma and death. So there is a wide range of manifestations, just behavioral abnormalities in the beginning. From that point, the patient may develop gradually coma, convulsions, and even eventually death. So clinically, hepatic encephalopathy is staged: stage 1, stage 2, stage 3, stage 4, like that. So these are all complications: hepatic encephalopathy, jaundice, theater hepaticus. Theater hepaticus is a musty sweet odor from the mouth. This is because of production of mercaptan. Mercaptan is a substance which is produced from the sulfur containing amino acids by the action of bacteria in the gut. So this is mercaptan substance is responsible for the abnormal peculiar odor, sweet and musty odor emanating from the cirrhotic patients. And of course, there is coagulopathy. There is failure of coagulation leading to bleeding tendency, bleeding into the skin and mucous membranes because of reduced synthesis of coagulation factors. And there is pulmonary vascular shunts, gynecomastia, spider nevea, ascites, hepatorenal syndrome. Hepatorenal syndrome is a renal failure associated with cirrhosis. This is because of reduced perfusion, effective perfusion of the kidneys. There is a disturbance in the electrolytes and water, and in the case of cirrhosis, there is splanchnic vasodilatation. This leads to reduced perfusion of the kidneys. This leads to renal failure. Renal failure is not because of any structural abnormalities in the kidneys. Kidneys are functionally and structurally normal. Because of the hemodynamic changes, the perfusion of the kidneys is reduced. Therefore, patient develops hepatorenal failure, that is called hepatorenal syndrome. So that is about the manifestations of hepatic encephalopathy. So I have discussed in completely the various complications of cirrhosis, and we will start about infections. So most important infections are pyogenic infections, which are common in AIDS patients or patients with immunocompromised individuals and all these things. But for examination purpose, this is frequently asked. That is amoebic abscess of the liver. Amoebic abscess of the liver is a complication of amoebic dysentery. Amoebic dysentery is caused by Entamoeba histolytica, the protozoan, and the abscess is usually single, situated in the right lobe of the liver, and abscess is a cavity filled with pus. What is pus? Pus is necrotic liver cells, cellular debris, red cells, and of course infective organisms will be there in the pus. So abscess is enclosed by granulation tissue or fibrous tissue. So amoeba may be found in the inner wall. If you examine microscopically the margins of the abscess, you may find amoeba. This is the gross specimen of amoebic liver abscess, which shows a loculated abscess mostly occupying the right side of the right lobe of the liver. So brownish or blackish necrotic material is in the center, and almost mostly circumscribed abscess is there, mostly occupying whole of the right lobe. So abscess must be drained. The surgeon will detect the abscess in the liver clinically by hepatomegaly, and also by using a CT or ultrasonography, and under the guidance of radiological guidance, he puts a needle and aspirates pus from the abscess. So this is this container, he shows aspirated pus, brownish thick pus, which is odorless, unlike other abscesses which are foul smelling. Amoebic pus, abscess pus is not foul smelling, it is odorless, brownish. So this is described as chocolate colored or anchovy sauce appearance, chocolate sauce appearance because of brownish color. And histologically, if you take section from the wall of the abscess, you can see in the center many rounded eosinophilic pinkish structures which are amoebae, trophozoites of Entamoeba histolytica. Plenty are there along with few inflammatory cells. And surrounding the abscess, you will find granulation tissue which is infiltrated by acute and chronic inflammatory cells. And outside the abscess, you can see at the periphery the liver cells. Most of them are degenerating or necrotic. So what is the outcome of abscess? Abscess, amoebic abscess of the liver, develops because of chronic amoebic dysentery. There are ulcers in the colon, and amoebae penetrating deep into the wall of the intestine, penetrate into the portal venous radicals, and they are carried by circulation to the liver. And initially liver shows amoebic hepatitis, and localization of inflammation, amoebic hepatitis leads to abscess formation. Abscess is generally measuring about 5 to 6 centimeters in diameter, circumscribed, and surgeon generally the clinical and radiological diagnosis hints at the abscess in the liver. It cannot be missed. So the treatment is aspiration of the pus. So surgeon puts the needle, Vim Silverman needle, and aspirates brownish, odorless pus. And he administers anti-amoebic drugs. So that is the treatment. So untreated, the abscess may burst into various cavities or sites. For example, abscess may erode into the lung, producing lung abscess. It may erode into the pericardial cavity, producing pericarditis, pericardial empyema, pericardial effusion, or it may penetrate the capsule, producing peritonitis. Inflammation of peritoneum is called peritonitis, or it may rupture over the skin, also discharging pus onto the surface of the skin. So these are the various complications or outcomes of amoebic abscess. So now we go to the tumors of the liver. Tumors of the liver may be benign or malignant. Most important, most common carcinoma, malignant tumor is hepatocellular carcinoma. I will discuss in detail under various side heads. And next common is cholangiocarcinoma. Hepatocellular carcinoma arises from the hepatocytes. Cholangiocellular carcinoma arises from the bile duct epithelium, cholangiocytes. And we also discussed the diseases of the gallbladder. Most important, gallstones. Formation of stones in the gallbladder is called polylithiasis. Stones in the gallbladder. And this leads to inflammation of the gallbladder wall, that is cholecystitis. Inflammation, itis means inflammation, cholecystitis, and sometimes rarely it may lead to stones may be produce carcinoma of the gallbladder. And next we go to the diseases of the pancreas. So we'll first classify tumors of the liver. Tumors of the liver may be primary or metastatic, secondary tumors. Metastatic tumors are secondary tumors are most common. They are multiple, distributed all over the liver parenchyma. They are most common compared to primary tumors. Metastatic tumors are more common. They are always malignant, and malignancy is from the gastrointestinal tract, stomach, colon, and also pancreas, and also lung and breast also metastasize to the liver. But most important, but we are interested in the primary tumors of the liver. Then primary tumors may be malignant, benign or malignant. Benign tumors are cavernous hemangioma, most common. Next, hepatic adenoma and bile duct adenoma. Malignant tumors, most important, most common, hepatocellular carcinoma. Next common, cholangiocarcinoma. Next, angiosarcoma. Can you match the benign tumors from the against malignant tumors? They are not corresponding. For example, benign tumor of blood vessels is hemangioma, cavernous hemangioma. Malignant tumor is angiosarcoma. Similarly, benign tumor of liver cells is hepatic adenoma. The malignant tumor of liver cells is hepatocellular carcinoma. Benign tumor of bile duct epithelium is bile duct adenoma. The malignant counterpart is cholangiocarcinoma. So this is matched here. Now this is the picture of liver, which shows multiple secondary deposits, metastatic carcinoma deposits. The deposits are seen in both lobes of the liver. They are widespread and varying in size. Discrete or confluent, multiple metastatic deposits are there in the liver. Primary may be in the gastrointestinal tract or lung or breast. So this is the picture of cavernous hemangioma. Cavernous hemangioma can be characterized by dilated vascular spaces containing red cells, some containing red cells, and separated by the fibrous stroma or normal liver cells. It is a benign tumor. And we are interested in hepatocellular carcinoma. Hepatocellular carcinoma is most common primary malignant tumor of the liver. Your answer must be first. What is hepatocellular carcinoma means? It is most common primary malignant tumor of the liver. Similarly, you should answer when what is renal cell carcinoma. You should ask. You should tell in adults renal cell, clear cell carcinoma is the most common primary malignant tumor of the kidney. So like that you have to answer in the examinations. So here this is most common. That's why we are discussing in detail. Hepatocellular carcinoma affects older patients, particularly males. Males to female ratio is 3:1. And the risk factors for development of hepatocellular carcinoma are: one is chronic hepatitis due to hepatitis B or C, alcoholism, aflatoxin. Aflatoxin is a toxin produced by Aspergillus fungus, Aspergillus flavus, a fungus which contaminates peanuts and grains, groundnuts, barley, rice grains and other grains which are improperly stored. So these grains, groundnuts and others are frequently contaminated with a fungus, and this fungus produces a toxin that is called aflatoxin. Aflatoxin is the risk factor for development of hepatocellular carcinoma. And other less common causes are tyrosinemia and hereditary hemochromatosis and others. So in hepatitis B virus, the presence of hepatitis B X protein causes inactivation of host cell proto-oncogene with disruption of cell cycle control. Aflatoxin causes mutations in the proto-oncogene or P53 tumor suppressor gene. So these conditions may directly produce hepatocellular carcinoma, except alcoholism. Alcoholism produces hepatocellular carcinoma in the background of cirrhosis. But others can produce without cirrhosis hepatocellular carcinoma. And this tumor is more common. The etiological agents are different in different regions of the world. In Western Europe and also US, most important cause is alcoholic liver disease, which and also less commonly hepatitis B virus and C virus, chronic hepatitis and hemochromatosis may produce cirrhosis, and cirrhosis progresses to hepatocellular carcinoma. In Africa and Southeast Asian countries, hepatitis B virus and C virus are endemic, and also aflatoxin can also contaminate the grains and the foodstuffs that both produce hepatocellular carcinoma. And hepatitis B virus and C virus can produce hepatocellular carcinoma without cirrhosis, particularly in chronic carriers who acquire the infection in childhood. They may develop hepatocellular carcinoma at an younger age without an intervening cirrhosis, without development of cirrhosis. That can occur in case of hepatitis B and C viruses. So this is about the geographical distribution of this. You can see here the prevalence of hepatitis B virus infection. It is endemic in Africa, southern China, and Southeast Asian countries, where hepatitis B virus infection is endemic. It is less common in European countries and also in the US, except in southern South America. Most of the cases of hepatocellular carcinoma develop in the background of cirrhosis. 80% of cases of hepatocellular carcinoma develop in the background of cirrhosis. Cirrhosis has many causes, but most common is alcoholic cirrhosis, alcohol abuse. And remaining 20% of hepatocellular carcinomas arise in the normal livers or from pre-existing hepatic adenomas. And there is a variant of hepatocellular carcinoma that is called fibrolamellar variant, and that carries a better prognosis compared to the classical type, and it occurs in normal livers of young people. You can see here 3 patterns. One is it involves mostly right lobe, large single tumor. In the middle picture, you can see multiple tumors, multifocal form. The third one shows diffuse pattern, growth pattern. These are the 3 growth patterns: solitary, multifocal, and diffuse. So grossly, the tumor appears as soft yellow-green or reddish mass of varying size, and these are the 3 basic patterns grossly encountered. So this is a gross picture of hepatocellular carcinoma in cirrhotic liver. The dark brownish or blackish appearing areas represent hepatocellular carcinoma. The brownish or yellowish brown appearance, cirrhotic nodules. The cirrhotic, so hepatocellular carcinoma has arisen in the background of cirrhotic liver. Cirrhotic nodules are there in the rest of the liver. So this also shows the different pattern of growth, which is almost circumscribed, solitary, and few satellite nodules are also there. And this is hepatocellular carcinoma in the background of cirrhosis. This is normal liver. There is no cirrhotic background, but the whole lobe of the right lobe of the liver is occupied by large tumor mass and a small satellite nodule at the periphery. So this is hepatocellular carcinoma in the background of normal liver, non-cirrhotic liver. Grossly, microscopically, the tumor cells resemble hepatocytes, normal hepatocytes, and they may vary in the degree of differentiation, ranging from well differentiated to highly anaplastic lesions. And pattern of growth, there are 3 patterns. Trabecular pattern, most common. The tumor cells shows tendency to invade and grow into the blood vessels, and so pattern of growth and cytological features help us to differentiate hepatocellular carcinoma from normal hepatocytes in the normal liver, also from the cirrhotic nodules in the cirrhotic liver. So pattern and cytological features are important. That 4 patterns are described. One is trabecular as sinusoidal pattern, pseudoglandular as acinar pattern, compact pattern without any sinusoidal spaces, scirrhous pattern which shows abundant fibrous stroma surrounding the tumor nodules. These are the 4 patterns which are important and help to differentiate from the normal or cirrhotic liver cells. So this tumor, you can see the thick trabeculae surrounded by sinusoids, Most of the sinusoids are empty. They do not contain red cells. This is sinusoidal pattern. High power view shows cytological abnormalities by which we can differentiate from the normal. The cells resemble normal hepatocytes. That means the tumor is well differentiated. The points of diagnosis are enlarged nuclei, vesicular nuclei with prominent dot-like nucleoli. Cytoplasm is abundant, eosinophilic, and still they are surrounded by sinusoids and lined by Kupffer cells or endothelial cells. High power shows same pattern. This is actually poorly differentiated hepatocellular carcinoma with anaplastic features, markedly enlarged nuclei. Many mitotic figures or apoptotic cells are seen. Hyperchromasia, pleomorphism, multinucleation, all these are features of anaplasia or poorly differentiated tumors. Another important pattern is pseudo-SNR pattern. Pseudo-SNR pattern, gland-like pattern. Within the lumen of the glands, you can see here inspissated brownish or dark brown bile. Dark brown bile is surrounded by tumor cells. This is called pseudo-SNR pattern. These SNI are not real SNI. They are pseudo-SNR patterns. And clinically, there will be enlargement of the liver, hepatomegaly. Patient gets pain in the right hypochondrium. On palpation, the liver is tender. On examination, patient shows jaundice, fever, weight loss, weakness, and there is a portal hypertension, and there is development of esophageal varices, from where patient may develop bleeding. Ascites may be there, and here you have to differentiate the ascites from cirrhosis of the liver. In cirrhosis, the fluid is transudate. It does not contain much of protein, and also RBC absent. In simple cirrhosis, not complicated by hepatocellular carcinoma. In hepatocellular carcinoma, you will find ascitic fluid containing RBCs and malignant cells, which are found in 50% of patients. So this is called malignant ascites. So rarely you can see other endocrine manifestations: hypercalcemia, hypoglycemia, polycythemia because of secretion of erythropoietin, gynecomastia, and other things. So most important fatal complications are liver failure, hemorrhage from esophageal varices, and intraperitoneal hemorrhage. The tumor may rupture and may lead to bleeding into the peritoneal cavity, which could be fatal. Spread. Malignant tumors spread. They invade the surrounding tissues and spread. There are various ways of spread. Most important pathway of spread is intrahepatic spread by hematogenous route. Multiple satellite nodules may be seen, which we have seen in the previous picture. One satellite nodule outside the main mass. So that is because of a intrahepatic spread of a tumor within the vessels, blood vessels, and extrahepatic outside the liver, spread outside the liver. Extrahepatic spread may also occur via the hepatic or portal veins to different sites, chiefly lungs and bones. And lymphatic spread can occur into the regional lymph nodes, particularly the lymph nodes in the porta hepatis, mediastinal, and cervical lymph nodes, which are distant lymph nodes. Further spread leads to distant nodal metastasis. And the metastasis may resemble the primary tumor, primary hepatocellular carcinoma, and the causes of death are cachexia, massive bleeding from esophageal varices, and liver failure and hepatic coma. So diagnosis is made by liver biopsy. That is important. And alpha fetoprotein is produced in some cases. More than 500 micrograms per deciliter are diagnostic. They are supportive. But the tumor cells can be so immunohistochemically they are positive for alpha fetoprotein, and diagnosis must be made by liver biopsy under the guidance of CT or ultrasonography. Needle biopsy under the radiological guidance. So that is diagnostic. Just a variant of fibrolamellar carcinoma, which occurs in less than 5% of cases. And you can see histologically polygonal cells, polygonal cells, hepatocyte-like cells surrounded by dense fibrous stroma. It is not associated with hepatitis B virus infection or alcoholism or any cirrhosis also. It is like common, it occurs in females at a younger age. It is not associated with cirrhosis or hepatitis B virus infection or other things. Etiology is not known, but usually appears as a solitary mass which can be resected surgically, and treatment may be curative. Here you can see the single mass, and grossly microscopically you can see the polygonal cells with abundant eosinophilic cytoplasm, which resemble normal hepatocytes and surrounded by dense fibrous stroma, that is called desmoplasia. So prognosis is good in case of fibrolamellar variant of hepatocellular carcinoma. Now we go to the cholangiocarcinoma. Cholangiocarcinoma is a tumor arising from malignant tumor arising from bile duct epithelium within the liver. This is less common, and etiological factors are exposure to radio opaque dye, that is thorotrust, anabolic steroids, cholonarchis sinensis infection, and fibrocystic disease. The tumor affects older people, and the clinical features are those of hepatocellular carcinoma, but with prominence of jaundice. Grossly, you can see here, this is the gross picture. Grossly, the tumor is whitish, firm in consistency, more or less homogeneous, without hemorrhage or necrosis. This is the liver showing cholangiocarcinoma. Tumor is found to hard in consistency, whitish. Microscopically, you can see here glandular structures, irregular glands lined by cuboidal epithelium and surrounded by fibrous or collagenous stroma. This is another picture. Irregular angulated neoplastic glands with dense collagenous stroma or fibrous stroma, which is called desmoplasia. This is the microscopic appearance of cholangiocarcinoma. So microscopically, the tumor has glandular pattern. The tumor cells resemble biliary epithelium, but without bile secretion. They form various patterns such as tubular, ductular, or papillary. Stroma consists of fibrous tissue with little or no capillary formation. Occasionally, mucinous, signet ring, or adenosquamous types may be present. An uncommon variant is combined hepatocellular carcinoma and cholangiocarcinoma. That is rare. So this finishes diseases of the liver. Now we go to the diseases of the gallbladder, biliary system. Gallbladder is very important organ in the biliary system. So this is the anatomy of the gallbladder. The gallbladder is situated on the inferior surface of the right lobe of the liver. and it is connected to a duct that is called cystic duct. So gallbladder bile drains through cystic duct into a common bile duct, which is formed by right hepatic duct and left hepatic duct. So after joining with cystic duct, the common hepatic, I'm sorry, it is wrongly written there. Common, that is not common bile duct, that is common hepatic duct. Above, you can see right and left hepatic ducts joining together, forming common hepatic duct, not common bile duct. Common hepatic duct. Common hepatic duct joins cystic duct to produce a common bile duct. That is wrong there. So that is common hepatic duct. So common bile duct drains. It is long enough, and it drains into the second part of the duodenum. Before emptying into the second part of the duodenum, it joins pancreatic duct in the ampulla of water. In the ampulla of water, that is the drainage system of biliary tract, gallbladder and biliary tract. This is the histological picture I will discuss in detail in the next picture. So this is the histological picture of gallbladder, normal gallbladder, which shows a mucosa and muscular wall and serosa. Mucosa is lined by single layer of columnar cells, and there is no submucosa. There is small amount of lamina propria, and the wall consists of irregularly oriented muscle fibers, smooth muscle fibers. Some are circular, some are longitudinal, some are oblique, and serosa contains blood vessels and lymphatics. This is normal gallbladder. So gallstones is very important topic. It is frequently asked as a short notes question, 4 marks question in the university paper. So what are gallstones? Gallstones, the formation of stones in the gallbladder. Gallstones. This is technically called polylithiasis. What is polylithiasis? Formation of stones in the gallbladder. That is called polylithiasis. Lithiasis means stone formation, condition of stone formation. And gallstones are formed from the constituents of bile. What are the constituents of bile? It mainly contains cholesterol, bile salts and bile pigments, and also calcium salts, along with the phospholipids, water, electrolytes, and mucin and other less important materials, substances. So accordingly, the gallstones, they are formed from the constituents of bile. Most importantly, they are formed from cholesterol, bile pigments, and calcium salts. So these are the 3 important types of stones you can see in the gallbladder. They are found in varying proportions. And they are usually found in the gallbladder, but sometimes they may develop in the extrahepatic biliary passages. So, predisposing conditions are risk factors. Who are the people who develop frequently gallstones? They are females above 40 years, fertile, that is multiparous woman, obese people, fatty, people with intestinal disease like ileal diseases, flatulence, and some cases are familial. Familial cases are rare. So these are 6 F to remember about pathogenesis. So in most of these cases, these factors which I have discussed above in the previous slide, most of them are associated with increased cholesterol secretion, increased cholesterol synthesis and secretion. That is the main factor in all these, most of these conditions, whether it is associated with age factor, female factor, pregnancy, obesity, right? Most of these are there is in most of these conditions you find increased synthesis or secretion of cholesterol into the biliary passages. Now, the etiopathogenesis, actual stone formation. Stones actually they can be classified broadly into cholesterol from the point of etiopathogenesis. You can classify them as cholesterol stones and pigment stones. Cholesterol stones contain mainly cholesterol in the form of cholesterol monohydrate. Um, um, and the pigment stones contain calcium bilirubinate. So, in demography, geographical variation is different for these two types of stones. The cholesterol stones occur mostly in Western countries, European countries, and America, where the diet is mostly cholesterol. They are obese people having mostly a diet rich in cholesterol. So there you find cholesterol stones more commonly. Whereas in case in the South Asian countries, pigment stones are there formed. Pigment stones are common. Pigment stones are because of increased unconjugated bilirubin produced due to chronic hemolytic anemias, and also deconjugation of conjugated bilirubin by infections, biliary tract infections, and ileal gastrointestinal disorders. So you can classify, I told you in the beginning, cholesterol stones, calcium bilirubin pigment stones, and calcium carbonate stones. These three elements are there in the stones. There may be pure stones, mixed stones, or combined stones. So classification of gallstones is, there are two classifications of gallstones. One is based on the chemical composition. The second type of classification is based on the location. Location is gallbladder stones are in the biliary tract. Rarely they are formed in the biliary tract, extrahepatic biliary tract. So most important classification is based on the composition of the stones. Pure stones are less common, constitute 80%, 10% of stones. Pure stones may be cholesterol stones, pure pigment stones, calcium bilirubinate stones, and pure calcium carbonate stones. They are uncommon. Most common, 80% of stones are mixed stones. They are mixture of cholesterol, bilirubin pigment, and calcium carbonate. The third type of stones are combined stones. In combined stones, you will find nucleus. Center of the stone contains one substance, and outer shell contains another substance. They are called combined stones. Now we will discuss first pure stones, then combined stone, then mixed stones, and then combined stones. So the pure cholesterol stones, they may be single or multiple. Single stones, whatever the type may be, they pure cholesterol stones contain more than 50% of cholesterol monohydrate crystals. They form the stone. These cholesterol stones are more common in obese people. They are more common in Western communities. They appear with increasing age, and they morphologically, the stones are large, single, spherical. They are yellow, and cut surface shows crystalline are glistening appearance, and radiologically they are radiolucent. They cannot be pictured in plain X-ray. This is the oval yellowish cholesterol stone. Cut surface of the stone shows a glistening yellowish appearance, and this is another picture of cholesterol stone which shows glistening radiating crystals of cholesterol with a dark center. This is cut section of cholesterol stone. Now we go to pigment stones. Pigment means dark pigment. Dark pigment because of bilirubin. Bilirubin is dark. So pure pigment stones are there, primarily composed of bilirubin pigment. They are generally multiple, jet black, small, less than 1 centimeter in diameter, and mulberry-like external appearance. I will show the high power picture of a single stone. So the surface is not smooth and shiny. It is mulberry-like pigment stones, pure pigment stones containing calcium bilirubinate. Some amount of calcium will be there, which combines with bilirubin, unconjugated bilirubin. So it should be called calcium bilirubinate. Pure calcium carbonate stones. Pure calcium carbonate stones are rare. They are multiple. Gray white, usually small, less than 1 centimeter in diameter, multifaceted, fairly hard because of calcium content, and they are hard and they are radio opaque. Calcium is radio opaque, therefore the stones can be seen in plain X-ray without any contrast medium. So these stones are uncommon, multiple, and sometimes mixed with a paste, grayish paste-like material which contains calcium carbonate. Mixed stones are most common. They account for 80% of stones. They are mixed. They occur in Asiatic populations. They are mixture of bile pigment, calcium carbonate, and cholesterol, and also fatty acids. So all the three components are there in the mixed stones, and frequently they are multiple, multifaceted. They vary in size from sand grain to 1 centimeter in diameter, has a laminated structure, and outer color depends upon the substance last deposited. So it is mixture of mixed stones are mixture of bile pigment, calcium carbonate, and cholesterol, and of course also fatty acids. So whether they are radio opaque or radiolucent depends upon the amount of calcium. If calcium content is more than 20%, they can be visualized in plain X-ray. So these are the multiple, multifaceted mixed stones. Multiple, multifaceted mixed stones. You can see different color in different stones. The outer color depends upon the substance last deposited. That means you can see single yellow stone. That means the outer coat contains cholesterol. You can see dark stones. The outer coat must be the bilirubin pigment, and most of the other stones are grayish or grayish white because the last substance deposited is calcium carbonate. This is the cut section of mixed stones. So the varying color on the cut surface is because of different substances deposited in layers, layer by layer over a period of months or years. The stone is developing. Therefore, that each layer gives an impression of a particular substance. Yellow is cholesterol, gray is calcium, and dark color is pigment, bilirubin pigment. And combined stones, they are less common. They are comprised 5 to 10%. They are solitary, single, large, smooth surfaced, and combined means they have one type of material substance in the center and different substance on the outer shell. So pure nucleus, one of the stones shows a the pigment, a mixed nucleus, and outer shell is whitish. That means the outer shell contains a different calcium carbonate deposit. So pure nucleus with mixed shell or mixed nucleus with pure shell, either thing can happen. So these are the combined stones. And factors in cholesterol stone formation are, now we will actually reach a pathogenesis of cholesterol stone formation. Pathogenesis, various factors are there. These factors we have already discussed. Fatty after 40 hyper rich in cholesterol diet. So cholesterol, pathogenesis of cholesterol stone, here we should consider 4 factors. 1, 2, 3, 4. One, cholesterol is insoluble in water. Normally the bile contains some cholesterol. Because it is insoluble in water and it is rendered water soluble by detergent action of bile salts and bile lecithins secreted into the bile. So cholesterol that is normally secreted in the bile is kept in solution by the detergent action of bile salts and lecithins. So bile salts, for example, bile salts are water soluble. They are, and lecithins dissolve cholesterol. So there is a bond between these two. There is a bond between bile salts and lecithins, and small amounts of that they are called micelles. So cholesterol readily joins lecithins, phospholipids, and the outer shell is bile salts, which mixes with water. So that's how they are kept in solution. Water made water soluble for excretion. And when cholesterol concentrations exceed the solubilizing capacity of the bile, that is called supersaturation, cholesterol can no longer remain dispersed and nucleates into solid cholesterol monohydrate crystals. You should understand this. When the cholesterol concentration exceeds the solubilizing capacity or detergent action of bile salts and bile lecithins, then cholesterol can no longer remain dispersed and it nucleates into small crystals. Nucleation. It nucleates into small crystals, that is called cholesterol monohydrate crystals. So there is an imbalance between the lecithins and bile salts. So that leads to nucleation of cholesterol. Next, you can see another factor is by the microprecipitates of calcium salts act as nucleation centers. So cholesterol is deposited around small deposits of calcium carbonate, calcium salts, and other factors which facilitate stone development and development of the stone are, one is gallbladder hypomotility. Normally, gallbladder motility facilitates emptying of the contents into the duodenum. So when the gallbladder is less motile, the contents are retained, and that promotes crystal nucleation. That promotes growth of the stone, crystal nucleation, and growth of the stone. And the mucus that is secreted by the gallbladder accumulates into the gallbladder, and that permits aggregation of cholesterol stones, cholesterol crystals into stones. So mucus catches the crystals and permits aggregation into stones. So this is about pathophysiology of cholesterol stone formation. The causes of gallbladder motility or stasis may be parenteral nutrition. These are conditions where you find hypomotility of the gallbladder, prolonged fasting pregnancy, massive burns, oral contraception. And pathogenesis of pigment stones is different from cholesterol stones. The pigment stones contain unconjugated bilirubin. Normally, the unconjugated bilirubin in the bile is only 1% or less than 1%. Most of the bile pigment is conjugated bilirubin. When the concentration of unconjugated bilirubin increases, then it combines with calcium, most commonly due to chronic. So normally it is 1%. Unconjugated bilirubin is only 1%, less than 1%. But in chronic hemolytic anemias like sickle cell anemia, thalassemia, and other conditions, you will find the increase in unconjugated bilirubin, which escapes into the bile without conjugation. And this excess of unconjugated bilirubin combines with calcium and precipitates as calcium bilirubin salts. And precipitates as calcium bilirubin salts. In undeveloped countries, the pigment stones are often formed because of biliary tract infections. For example, as E. coli infection, Ascaris lubricoides, or Clonarchus sinensis infections. These infections promote deconjugation of bilirubin glucuronide. Bilirubin glucuronide is conjugated bilirubin. So deconjugated, these infections, in these infections you will find an enzyme, glucuronide deconjugating enzyme. So conjugated bilirubin is unconjugated, and unconjugated bilirubin joins with calcium, forming calcium bilirubin salts. So this is the pathogenesis of pigment stones. Clinical features. Majority of patients are asymptomatic. Stones are silent, and they may remain silent for several years. And if gallstones produce, if the present symptoms are present, they are because of inflammation and obstruction when they pass into the cystic duct or common bile duct. So the symptoms, most important symptom is biliary colic, a constant long-standing pain in the hypochondrium where the gallbladder is situated. So large stones usually cannot enter into cystic duct or common duct to produce obstruction. So pain is in the right hypochondrium is typical of gallstones. And complications of gallstones. Gallstones may be diagnosed by ultrasonography and CT. Symptomatic stones must be removed. Otherwise, some complications may develop. They are because of slipping of small stones from the gallbladder into the common bile duct. So when a small stone slips into the common bile duct, that produces obstruction to the bile flow. So patient develops obstructive jaundice, often intermittent, and rarely causes secondary biliary cirrhosis, but patient is jaundiced. You should know the features of obstructive jaundice, and this obstruction also facilitates ascending infection, cholangitis, and it is also associated with acute pancreatitis. So jaundice, the patient may develop obstructive jaundice. Patient may develop jaundice, persistent skin itching because of deposition of bile salts in the skin may occur. Clay-colored stools, and urine is dark because of presence of conjugated bilirubin in the urine. And other complications are very rarely the stone may cause ulceration of the gallbladder. When the gallbladder perforates, the adjacent inflammation may become connected with the intestinal loop. So what is happening here? The stone is there in the gallbladder. Gallbladder is inflamed, and the large stone is there. The mucosa of the gallbladder is ulcerated. There is perforation, and the stone escaped in the loop of intestine, duodenum or large intestine, whichever is close to the gallbladder, and this may cause obstruction, intestinal obstruction. An impaction in the ileum may produce intestinal obstruction. That is called gallbladder ileus. Gallbladder ileus. And of course, other complications. So late complications of gallstones, they are predisposed to carcinoma of gallbladder, a malignant tumor. This is uncommon and always associated with gallstones. It is usually adenocarcinoma, rarely squamous cell carcinoma. It may the carcinoma may develop rarely in the bile ducts. So gallstones are almost always associated with inflammation of the gallbladder. Inflammation of gallbladder is called cholecystitis. Inflammation of gallbladder is called cholecystitis, which may be acute, chronic, or acute superimposed on chronic. Chronic cholecystitis is more common, but acute cholecystitis is a surgical emergency. It is a surgical emergency. So acute cholecystitis we will discuss first, and then chronic cholecystitis. Acute cholecystitis is the acute inflammation of gallbladder. In 90% of cases, it is associated with stones in the gallbladder. Stone is obstructing the neck of the gallbladder. Therefore, the door is closed. When the door is closed, there is distension of the gallbladder with bile. The gallbladder is distended, tense, and reddish, with altered color on the surface. So this is a surgical emergency. Otherwise, there may be perforation and biliary peritonitis may develop, and patient may go into shock. So in 90% of cases, it is associated with stone obstructing the gallbladder of the neck of the gallbladder. In 10% of cases, there is no association with gallstones, but it appears in conditions like septicemic shock and other things. Acute cholecystitis. Clinical manifestations include nausea, vomiting, fever, leukocytosis associated with right upper quadrant pain, where the gallbladder is situated, epigastric pain, and liver function tests may be abnormal. Ultrasonography is diagnostic. Complications include empyema. Empyema is pus in the gallbladder. The gallbladder may be secondarily infected. Pus may fill the gallbladder. It may produce septicemia and shock. Gallbladder may go avascular. Gangrene may develop. It may form, an abscess may form, or there may be peritonitis. And acute cholecystitis is surgical emergency treated by cholecystectomy. Chronic cholecystitis is more common. It is almost always associated with stones in the gallbladder, polylithiasis. And supersaturation of bile with cholesterol predisposes to both gallstone formation and inflammation. Remember, the abnormal bile is sufficient to produce inflammation of the gallbladder. It is not always a secondary infection which causes cholecystitis. The abnormal bile, that is biliary sludge, that is called a biliary sludge, the abnormal bile itself can cause irritation of the gallbladder and inflammation of the gallbladder. So, in some patients, repeated attacks of mild acute cholecystitis may lead to chronic cholecystitis. Clinical features: chronic cholecystitis, it is insidious in onset, unlike acute cholecystitis, which is abrupt in onset with high fever, leukocytosis, febrile illness, and other things. It is gradual in onset. Patient is usually a fat, fertile female, 40, 50, 40 or 50, and presents with abdominal distension, epigastric pain or discomfort, especially after fatty meal, and there is constant dull ache in the right hypochondrium, and epigastrium and tenderness is there over the region of the gallbladder. Diagnosis is made by ultrasonography. Treatment is removal of the gallbladder, cholecystectomy. So after removal of the gallbladder, the surgeon sends the specimens to the pathology department for examination, and examination of the gallbladder, and to examine whether gallstones are present or not. If they are present, what are the types of stones? All these will be done in the pathology. So grossly, the gallbladder, I will show you the picture first. You can see the chronic cholecystitis gross picture. The wall is thickened, markedly fibrotic, thickened, opaque. The lumen is shaggy or irregular, greenish or with ulceration of the mucosa. So this is not normal. This is chronic cholecystitis. So gallbladder is generally contracted, but may be normal in size or enlarged. The wall of the gallbladder is thickened and cut section shows gray white appearance due to dense fibrosis, and that may be calcified also. The mucosal folds may be intact or thickened or flattened or atrophied or ulcerated, whatever it may be. And the lumen contains multiple mixed stones or combined stones. So gallstones are removed from this specimen. Histologically, this is the histological picture. This is the histological picture. Recollect the normal gallbladder histology, which I have shown you in the beginning. So the gallbladder is thickened, mucosa is congested, or maybe destroyed. There is penetration of mucosa deep into the wall of the gallbladder up to the muscular layer, and that forms a Rokitansky-Assoff sinuses. Rokitansky-Assoff sinuses. I will just show you. Here you can see the irregular glands, benign glands, penetrating deep into the wall of the gallbladder